Well, welcome everybody to the EMS Quality Improvement Partnership Airway Management Collaborative webinar, where we're going to be discussing the newest and most incredible national quality improvement project. We're here with a lot of our partners from around the country. As many of you know, I'm the president of the National EMS Quality Alliance. We're the organization that's sponsoring this EQuIP project. And we are doing it in conjunction with so many great people who have such knowledge and such deep appreciation for the importance of airway management in the pre-hospital setting and in EMS in general. And we're just really excited to be here today to talk about how this project will be moving forward. And so this is the outline of what we'll be talking about today. So one, we're going to describe what the EMS Quality Improvement Partnership is all about. We're going to talk a little bit about the framework on which it sits, the IHI Breakthrough Framework. And we're going to be talking a bit more about the details of the Airway Management Collaborative. We'll discuss the participant requirements and benefits, as well as answer questions and talk about the next steps of how you go about actually participating in this project. So all throughout, you're welcome to put your questions in the chat. We are a very interactive group, and we hope to answer all of the questions as we go. This is a big project. I'm sure lots of people will have lots of different questions about how we're doing it. So please use the chat, and one of us will answer the questions as they come up, and make sure that we answer all of the questions. Your questions will probably be questions that others have as well, and will be important to answer for anyone who's participating. So the EMS Quality Improvement Partnership, it's really based in the understanding that although we are making progress in terms of national guidelines, in terms of evidence for pre-hospital care, the EMS Agenda 2050, and as many of us who practice in EMS understand, that it's really challenging to get the best practices implemented in day-to-day EMS. And this project is really based in the idea that we've got to take this the last mile. And in order to support agencies to do the right thing, to follow the guidelines, and to really focus on what matters for patients when it comes to pre-hospital care. So this is kind of the idea of its inception. I have to say that it took a lot of, it took some nudging from Mike Tegman, a little whisper in our ears to start doing this work. But as you'll see, we've had some great success with lights and sirens, and we really want to apply these lessons to the airway. As many of you know, NEMSQA came about to kind of reinvigorate the drive to develop national EMS quality measures. We focused on clinical measures and patient-centered measures with focusing on quality and safety in this area. This is in 2019. We released the NEMSQA 1.0 measures, many of which you should be familiar with, but obviously include some respiratory measures, seizure, stroke, trauma, lights and sirens. And in 2023, we released the NEMSQA 2.0 measures, another set of 10 measures that also are diverse in their clinical perspective, but of note here included some additional airway measures, which obviously will be kind of our focus today. But we released the Airway 01, 05, and 18, which we'll talk about much later, and Respiratory 02. Along with some pediatric safety measures as well as others. So this is what it looks like, and this is kind of how the roadmap of an EQuIP project. And really the vision of EQuIP is to put the NEMSQA measures to work and create a national framework and infrastructure to support the EMS community to make quantifiable improvements based on the NEMSQA measures that allow for kind of an ongoing identification of national priorities to advance quality and safety. And so this collaborative of associations, organizations, and individuals focused on measurably and meaningfully improving care. And again, we think that, right, we are, again, the ultimate goal is to really to save lives. And as we go through this kind of structured way of approaching this EQuIP project, we hope that, right, from kind of putting all of these things together, that's where we'll get. The Lights and Sirens Collaborative was our first venture into this space, and in partnership with a number of national EMS organizations, instigated, as I said, by Mike Tegman, we started the first EQuIP, and this was again designed to focus on decreasing the use of lights and sirens, making a safer environment for EMS to work. This was in 2021. We launched it, and as you see, right, with the organizations that really took these lessons to heart, we were able to make some drastic improvements in the safety of their transport by reducing lights and sirens. And we produced this, if you haven't seen it yet, Improving Safety in EMS learning guide, which really takes the lessons that we had from the lights and sirens and packages it in a very easy to access way. I recommend it for all of you who are interested in reducing lights and sirens in your communities. So I'm going to turn it over to Mike. He's going to take us through the IHI Breakthrough Series. I'm just excited to be here. I'm really appreciative of all of the faculty and all of the people who have supported this effort along the way. There's been almost a year of development already, just thinking about how to best package all of the work that we're going to be seeing today. So thank you all. And Mike, it's in your hands.
Thank you, Michael. And I'm calling in from the Paramedic Chiefs of Canada conference. So I am in a hotel in Quebec City. It keeps telling me that my internet is unstable. I keep responding that it's not the only thing that's unstable in this room, but we'll talk through this breakthrough series framework. This is created by the Institute for Healthcare Improvement, probably close to 20 years ago at this point in time, when they realized that there were hospitals and healthcare systems all over the world kind of doing individual performance improvement projects, but the majority of patients in the world weren't getting the benefit of the improvement efforts. And there is some science that says once there is a scientific evidence behind a particular diagnostic approach or treatment or intervention for a disease state, that the time between when there's enough science to say this is the right thing to do and the time the majority of patients get the benefit of it is about 17 and a half years across the world. So this is a way of shortening that process so that the majority of patients get the benefit of the evidence and good quality care as soon as possible. So they put this framework together. The first one I think they tackled was unnecessary cesarean section rates, and worked on it with hospitals all over the place. And we have used this framework for our Lights and Sirens project, and we're going to use it as the basis for this Airway project. So the beginning of this project, Sheree, if you'd slide to the next slide there, it'd be great. Is to pick a topic where improvements have been made. So this is not research work. This is improvement work, and that's an important distinction. And then next slide, if you would, and bring together a series of topic experts, folks who have successfully made these kinds of improvements, academics who've done research in these areas, and really world-class experts. And we have assembled quite a faculty for this project. And then on to the next slide. And basically the faculty works together to create what we refer to as a change package, which is a list of things that you can implement in your own system to make meaningful, measurable improvements in the areas that we're focused on, in this case, airway management. And then the next step is we enroll EMS agencies. We can handle between 30 and 50 EMS agencies or systems across the U.S. and Canada to participate in this collaborative learning together. And then the next step is We will bring you to bring systems together to basically teach the improvement science framework. And I see a lot of friends in the circle here today. Maya and Mick Gunderson and Zachary and folks that I've worked with and taught improvement science with for years. So you can be a part of that education process, but we want to make sure all the systems are involved, understand the model for improvement, which is the next slide, Maya, if you or Sheree, if you would. And this is the improvement science framework that we've adopted. It's the one that the Institute for Healthcare Improvement has been using for about 32 years. And it basically is a series of 3 questions followed by an engine to do small, fast cycle testing and learning quickly. Next slide. The first question is, what are we trying to accomplish? And in the case of this project, our aim is to reduce the adverse events of peri-intubation hypoxia and hypotension. And next slide. And to improve the use of waveform capnography to confirm and monitor all invasive airways. And we've actually done a lot of work to kind of narrow down and focus on these 2. And then the second question is about measurement, and the measurement will come from our NEMSQA measures. So it's a successful first airway placement without hypotension or hypoxia is the first one. And then the next slide is the waveform capnography airway device monitoring used on all patients who have an invasive airway that is part of their care. Next slide, if you would. And then we go down to the change package, and this is a list of ideas that you can take and test and see how they work in your own system. Next slide. And then what happens next is that the participating systems in the collaborative will spend several months, usually about 6, testing the change concepts in their own system. And we have an online software platform where all participating agencies will collaborate together. You'll be able to see the learning and experiences and data from all the participating systems, so that you can basically swipe ideas from each other. This is the R&D process, which some people refer to as the rip off and duplicate process for figuring out what produces the best and most positive results in the system. On to the next slide. And so this is the first process of trying the PDSA cycles from the change package, sharing the learning, and we'll have experts to coach you and support you in your improvement work if you haven't done it using this kind of framework before. And then on to the next slide. And then you basically test these ideas, and then we share what we learn, and then we bring it all back together for the next slide. And the expert panel and the participants kind of work together and say, what do we need to revise in the change package? What have we learned so far? What works best? What doesn't seem to help? And then we go into another round of testing. Next slide. Second round of testing and learning, and then on to the next slide. And then we bring all of that learning together and put together an implementation plan and a finalized change package. The idea behind this, similar to our Lights and Sirens project, is that we publish something that all EMS systems can take and implement to improve the quality of airway care and management in their own system. And I think that is it for the Breakthrough Series section. We'll pass it off to Dr. Jeff Jarvis, and Mick said he shared his link for this to the NEMSQA quality meeting, and hopefully some of those folks will be joining us here. Thank you.
Guys, I want to talk about why we settled in on airway management as an improvement strategy, and then why now? Why we decided to do airway now instead of something else. So why don't we move on to the first slide here? So there are some fundamental reasons why airway management is important and why it is worthy of an improvement effort. So first is we are thinking about the EMS 2050 goal. One of the projects there, one of the goals of the project was to be people-centric. This was, by the way, a very specific Mike Tagman thing. The reason we did people-specific was to include our own clinicians and our own staff. Well, hopefully we're not doing a whole lot of airway management on our own staff. That's a truly bad day when we have to do that. So this measure is very patient-specific. It is also something we do an awful lot. Not quite as often as responding to calls and transporting to the hospital, but possibly one of the second or third most common things we do. As probably the world's most famous spider once told us, with great power comes great responsibility. I am a sort of a Marvel fan here. The reason I think this is important is we have the ability to truly make huge differences in patients' outcome based on how we manage their airway. But with that ability comes a really sharp-edged sword. We can flat out kill people. And I think, unfortunately, we have probably all heard of cases where EMS clinicians decided to take a patient's airway, whether it was appropriate or an inappropriate decision. The problem came when they executed it poorly. The patient had an esophageal intubation, or there was no oxygen flowing, any number of problems. So we can cause great harm, or we can cause great benefits. The good news about these adverse events is that they can be mitigated. And that's really what we want to try to do here, is take the lessons that we have learned through the past 30, 40 years of work on airway management and put them together in a package that we can easily share across the nation. So why don't we go over why these things are bad real quick. Just very quickly, I think most of us would agree hypoxia is harmful. One of the things that we know, particularly in patients with traumatic brain injury, is that the risk of death is fourfold higher. It's a 300% increase in the risk of death with even one episode of hypoxia. Same thing when we talk about how common this is. It turns out, of patients who are undergoing intubation for reasons other than cardiac arrest, somewhere between 45 and 48% of those pre-hospital intubations have profound peri-intubation hypoxia. This is bad. Peri-intubation hypoxia increases the risk of death. We don't like that. Death is bad. Now, if you'll go to the next slide, it turns out that for patients we are intubating that are not dead yet, about 2% of them end up in cardiac arrest because of the way we manage the airway. Now, this is not specific to EMS. It turns out it happens in the emergency department. It happens on the floor. It happens in the ICU. It happens everywhere outside of the OR, and the rate is fairly consistent across the years. It's about 2%. Now, if you were to ask yourself, what is the big reason that we don't see that? And pardon me, but as Mike said, apparently I have my daughter's lion down here who may or may not attack me. Hey, get down. Sorry about that. So if you ask yourself what is different about the intubations in the OR and intubations everywhere else, well, it turns out the OR has been using a pretty simple and readily available technology for a long, long time to confirm tube placement, and that is waveform capnography. So we have that now in the field, really no excuse not to make this a safer process. When you look at why these patients went into cardiac arrest, profound hypoxia. And as it turns out, as someone very wise once told me, the esophagus does not participate in oxygenation very well. So that tube conformation and how we go about doing the airway is really important. So go to the next slide, if you will, please. One of the things we learned from the EPIC trial that Dan Spate did down in Arizona, he looked at a ton of patients with TBI. And what we found is that the rate of hypotension, the rate of death with patients who have one episode of hypotension compared to none goes up by fourfold. If you have one episode of hypoxia, sixfold. If you have one episode of hypoxia and hypotension, 13-fold. So a 13-fold increase in the rate of death if you have hypoxia and hypotension. So hypoxia, hypotension, bad, we should avoid them. And as we get to the measures, you'll see that's why we picked the measures we picked. If you'll go to the next slide, we'll talk about the other component of our Airway 01 measure, which is first pass success. The reason we are so focused on first pass success is failure to achieve first pass success is associated with an increased rate of adverse events. And the primary, adverse event is hypoxia. Hypotension is also associated with failed intubation attempts. So the more attempts we make, the more adverse events we have. So if we can avoid hypoxia, if we can avoid hypotension, and we can get the tube in the first attempt, the patient is going to do much better. So let's talk about why now. Sure, if you don't mind, there we go. Why now? It turns out, I think we've known airway management was important for a long time, but we have a confluence of national events that I think make now a prime opportunity to work on this improvement effort. So several years ago, 2022 to 23, when Dr. Mike Levy was president of NAMSP, what he wanted to do is create this Airway compendium. So this is the title editorial for this compendium. It is a series of papers and position statements from the National Association of EMS Physicians that addresses a lot of different concepts within airway management. Each one of those areas down below there is a specific position statement within this compendium. So we have things on optimizing physiology, on using drugs to manage airways, on supraglottic airways, and on non-invasive management. All of these things have their own position statements. So there was this huge effort to look at the literature and come up with a pragmatic guide, and that's what these papers are. Now, I mentioned the pragmatism of that. At the same time, next slide if you don't mind, we had a federal grant to create evidence-based guidelines that were very focused on what does the evidence say. So the compendium was all about pragmatism. This was all about a strict interpretation of the literature. This just came out early this year and really dives into what is the literature saying. And one of the things the literature is saying is emphasizing the importance of first pass success, hypoxia, hypotension avoidance, and the use of waveform capnography. All right, let's go to the next one. And then there's this little thing of, hey, we have some great ways to measure improvement. We have, Michael talked about our new airway measures, or our new measures in general, and we have some airway ones. So these are great measures, and they allow us, as Mike Tagman pointed out, if you're going to improve something, you really need to know whether you made an improvement or not. These measures are going to be what help us out with that. So what I'd like to do is just finalize this and say, well, what is the aim of the project? Just to be real clear, we want to do two things here. We want to improve the use of waveform capnography, both for confirmation of tube placement and monitoring tube placement. And when we say tube placement here, we're talking about any invasive airway. So supraglottics, extraglottics, and endotracheal intubation. And then we want to reduce the adverse events around peri-intubation hypoxia and hypotension. So this is specifically for intubation. We do have a couple of measures, and these are the ones we're looking at. Specifically, Airway 18, that is the one dedicated to waveform capnography. Again, confirmation management. Respiratory O2, which is if you have a patient with respiratory distress who is hypoxic, do something about that. Give them some oxygen. Pretty simple measure. And then the decidedly not simple measure is Airway 01. This is intubation, first pass success without hypoxia or hypotension. So what do we know about performance on this measure? Well, if we were doing really, really well on these measures, there wouldn't really be much of a need to improve. But if you look at these measures, what you will find is, oops, we're not doing so well. We do have some room for improvement. Waveform capnography, confirmation and monitoring, very, very, very low. This is deeply disturbing to me. And I will tell you, a lot of people will just jump to saying, you know what, this is just a data problem. I don't think this is a data problem. Ask yourself how many agencies are still using colorimetric in tidal CO2 devices. Ask yourself, to really be scary, how many emergency departments are still using those stupid colorimetric things. So this is probably an accurate reflection of our need to do better. If you look at first pass success without hypoxia or hypotension, it also turns out we're not doing very well. We're looking for adults around 23%, for kids around 30%. Huge opportunity for improvement here. And even oxygen administration for patients with hypoxia and respiratory distress, we have room for improvement. So with that, why don't we talk about how we can go about improving this? Who's going to help us do this improvement? Well, it turns out this is our faculty. Here's who's going to help us do this. So this is the faculty for us. And these are the groups, these are the folks who have worked on airway management improvement programs and have agreed to help share what they've learned. So with that, I am going to turn it back over to a Mike.
Yes. All right. Well, listen, so we are going to be, we're going to identify the max of 50 agencies across the country that perform, the agencies, whether ALS or BLS, have to be able to perform, sorry, I misspoke on this, but they have to perform any invasive airway procedures. So this is where it's complex, and I'll just describe it and break it apart specifically for you here. So any agency, whether ALS or BLS, that performs invasive airway measures, either supraglottic airways or endotracheal intubations, can participate in the overall project. And for Airway 01, so we're going to, again, there'll be a differential between some agencies, but every agency that does an invasive airway can participate. Only agencies that perform endotracheal intubation for patients who are not in cardiac arrest will report the specific Airway 01 measure. So sorry if that was confusing, but again, it will be, if you do endotracheal intubation or supraglottic airway placement, you can participate in this program and project, but we'll be limiting the measures that you take a look at during the process of this program. But if you do endotracheal intubation, we'll be looking at Airway 01 in particular. This is what it requires. And again, we don't want to be shy about telling you that this is a commitment, right? This is you're making a commitment to work on improving airway. And this is what it will entail. And we invite you and encourage agencies to show up, but again, if you have to understand that this is what the commitment is. So there'll be 4 virtual learning sessions, and they're about 4 hours apiece throughout the course of the project. We're going to ask that you share performance data on the quality measures of your agency and system for Airway 18 and Respiratory 02. Those are for everyone. And Airway 01, if you are, use endotracheal intubation as one of your strategies for airway management. You're going to implement strategies from the change package for improvement. You're going to share your experiences with the larger learning collaborative. And you're going to document and share qualitative data on improvement efforts. Like, what did you do when you're doing your plan, do, study, act cycles? And what is the larger learning, or the point of what you learned throughout that experience? And again, the last requirement is something, and again, there'll be a QR code for you to learn more about becoming a NEMSQA agency member, but you have to, in order to be part of this project, you have to be a NEMSQA agency member. What do you get out of it? And right, so what are the participant benefits, right? And I think one is that you'll be in this collective where we're going to drive meaningful and measurable improvements in pre-hospital airway management, right? It's a valuable experience to be with peers so that you can understand how you're doing, what are the lessons that they're learning, how do they apply to your agency or organization. I mean, this type of stuff people pay a lot of money for, and we want to, again, we believe that this is important to get out into the community. And again, I think we have a valuable opportunity, a unique opportunity, really, to get education from one another and from national faculty who are content experts in airway management. Will be knowledge sharing and networking. There'll be different opportunities to learn evidence-based quality improvement techniques. And again, you'll have access to kind of other people's change ideas and improvement strategies that you'll be able to apply to your agency. You'll get quarterly live sessions as described, one-to-one coaching, some assistance with data analysis, and credit as a participant in this national collaborative in a published document around airway management change and improvement. And most importantly, we think that your participation in this program will help you save the lives of your patients that you are treating every day. Here's the timeline, right? So, we're starting to open the applications. I think I'm not sure how many we've got secured already, but I know last time I checked, it was just about 9 or 10. But I think it's been about a week or so since I've checked. And we will be selecting the agencies in July of 2024, and then starting our first learning session in September of 2024. And then throughout late 2024, Q4 2024, and through the summer of 2025, we will be implementing our change packages with all of our member agencies throughout the following year. And then in October of 2025, we really expect to be able to have a summative Congress, which is really a place where we gather all of the information and we get everyone together to share their final kind of experiences and learnings with the rest of the group. And after that, we'll put together a change package for the general community, which we think will be a valuable tool for people who are interested in improving airway management in their agency or area. Okay, so this is the point. This is the part, and I'm happy we have a lot of time to answer questions about some of the details. Thanks for asking the questions in the chat, but feel free to come off mute, put your hand up, and you can ask anything you'd like about next steps and what we do. So Mick.
Yeah, two questions. One is, in the process that you're going to be using for this, will there be a capture of baseline data before the intervention is made? And the second question is, will there be any control of the denominator to make sure that all of the eligible cases at each agency are actually entered so we don't end up with a bias of only reporting on the cases we got a complete data set for?
Both really, really good questions, Mick. On the second one, we'll certainly provide guidelines for kind of gathering and sharing data. One of the challenges is when you're working with a bunch of different organizations, you don't have the ability as a national organization to get into the weeds on how they actually calculate their data, but we'll certainly give them guidance and best practices and endeavor to make sure it is a complete data set from that perspective. And then one of the challenges is some places haven't been measuring this beforehand, so we will endeavor to get baseline data from the places that have. And some organizations, we found this with our Lights and Sirens project, didn't have an ability to really get a baseline, so they're kind of starting from scratch, and that's the beginning of their baseline. But if they've got historical data, we'll certainly, our hope would be to ask for 20 months worth of data points beforehand, so we can start with a control chart for them.
Okay, and will the data points be monthly, or are you going to have more granular data than monthly?
with these particular topics, depending on the size of the system, these are events that don't generally tend to happen daily unless you're in a massive system with a lot of calls, right? So monthly data is probably going to make more sense than anything from a shorter time frame for the majority of participants.
Okay, very good. Thanks.
I see Catherine Counts has put some questions in the chat. And those are also great questions. Does anybody want to take a stab at that, Mike or Jeff? Or
actually, Counts, would you be willing to unmute and jump in?
I can unmute, but I have a child that's having breakfast number 2, so she's slightly disruptive.
That's not a problem.
At least you're not wearing chicken pajamas.
That's right.
I'm not wearing chicken pajamas, but she's wearing unicorn pajamas.
So Counts, you're asking what level of performance is optimal for a participating agency to start at, and so I think there's a couple of possible answers to that. If you're an agency where your performance is really rocking these measurements, we'd love to have you participate because we want to learn from what you're already doing well. Our experience and prediction is that most organizations are not optimized in these metrics. So one of the things in improvement work is if you've got low performance, it allows you to see more improvement faster. Does that make sense at all?
Yeah, I mean, that makes sense. I also think like no one's at 100% or 0%, depending on the measure. So anyone who thinks that they're too good to participate has their own problems. But I just wanted to make sure that, like, I guess a higher performing agency isn't going to quote unquote take a spot from a lower performing agency because like they do have less room for improvement.
That makes sense. My experience and prediction is that we're not going to have an overabundance. I doubt we're going to go over 50 applicants for this, but we'll find out. It'll be interesting.
Okay.
And Counts, I think especially when we're talking about Airway 01, I think the concern about people who have maxed this out, boy, is that a concern for pretty far in the future. This
a girl can be an optimist, Jeff. Come on.
I like it. I like it. It's a tough measure. And I think the best we've been able to identify, even the folks who are truly smoking this are around 70%. And that's really good. So it's I think there is a ton of room for improvement.
So a lot more good questions and Counts just to your second question, the optimal makeup of an agency team, which humans and roles do you expect to participate? I think we understand that many agencies are constructed differently with different levels of support and leadership just that exist at the baseline. And so I don't think that we are prescriptive about who is participating, but what I do think we need is that there's a commitment from the organization that participates, right? We've seen this in our NAMSQ quality courses, but we've also seen it with the Lights and Sirens project that we need to have a commitment, right? If there's the organization is committed to doing it, then I think that we will, they should participate in that. But we need to make sure that that's part of the deal when you sign up. There's a few other questions, and again, I think I'm not sure that we have all of the answers, but Michelle Moss, you're asking about participating with the LEMSA, and I'm not sure. Cherie, if you can remind me if we said that we would participate with kind of a collaborative organization, or did we want to stick with standard EMS organizations?
So we do have in our application the opportunity for systems. I'm saying at this point because everyone is going to be unique, that I will connect with folks who are looking to enroll a system so that we can appropriately accommodate both the volume and make sure that it's appropriate. The way our application reads is when we're looking at system enrollment, we really want to make sure that system is going to be functioning as a single quality improvement unit, in that there aren't going to be many, and this is from our lights and siren experience, a lot of different EMS agencies who aren't going to be doing the same interventions throughout together as one, because that's really not one system operating together. It's a group of individual agencies operating sort of separately. So I will connect with these folks who are looking at enrolling systems to make sure that we account for and enroll them appropriately.
The next, anybody wanted to respond also, or I'm going to move on to the next question.
I think that probably addresses Zachary's question also.
Got you. The question about the recording, yes, it will be available for everyone to share widely, right? We'd love to, use this forum to help support agencies that are interested in doing it and getting the right stakeholder engagement. I think we think that would be great, and we'll provide that link once we're finished. For Bubba, the rural EMS experience is something that we definitely want to capture. And again, I think the challenges and the frequency of intervention will be less, but we are interested in figuring out how to create an engagement with rural EMS. Obviously this is a big component of EMS in the United States and across North America. So we definitely invite our rural EMS, as long as the agencies meet the requirements of having the invasive airway use.
And the other piece around that, Michael, and I was just texting back and forth with some of the faculty, the space in between the first two learning sessions, we may extend that in order to be able to have rural agencies have more opportunities for intervention in the first learning session, considering that the frequency of the cases where these interventions are needed is going to be less in a rural place for more effective inclusion.
And Michael, you just mentioned agencies in North America, which I think gets to Mick's question.
Great. All right. So the answer, and again, I think that we haven't limited it to the United States proper. I think that we are open to having both, agencies in United States and Canada join. Again, we haven't thought. Actually, maybe it's just me, but I haven't thought specifically about outside of kind of North American context. But I wouldn't be necessarily against having agencies from outside the country join. I think it would be an interesting opportunity to learn from other folks as well.
It turns out, I think the main limitation will be more language than geography, because obviously it's a virtual effort. The key requirements are that you be a NMSQA member to participate, and that you're able to communicate in English. And obviously lots of folks are able to do both of those all across the globe.
Does the NMSQA membership restrict to USA or just North America?
I think that's probably best for Cherie to answer. As far as I know, we don't.
We may have to change the N to an I, but otherwise, right?
Well, I can chime it in and say that, oh, sorry, I'm echoing. You can select other countries on the application.
Okay, fair enough. Thanks.
Brooke, I think the echo is from your Aurora behind you.
And Tim's got his hand raised.
Yeah, just real quick, just so I'm clear on hey, before I put in our application, I want to run it through our multiple medical directors. In the end of the PDSA cycle, the change is not going to include protocol derivatives, because sometimes with multiple geographies that we cover, I don't have a direct ability to influence, consistent change across, so we have medical controls that say this in a certain area and say this in a certain area, but we can employ practices or procedures internally that, get us to the same endpoint without changing a protocol. That's not the specific intent of this, is it?
There may be some protocol changes involved in this process. I would be lying to you if we said that this could not result in some protocol changes.
But would that be in the end recommendation package, or would that be in this process itself?
It'd be in this process itself.
Okay.
Yeah, for example, you could say that use of waveform capnography is a required part of your protocol, and that may not be in your protocol already. So a change to the protocol may be one of the improvement efforts.
Yeah, and I was just considering like that one. I think would be very easy to employ internally and just say, hey, protocol doesn't require it, but we do. It's above and beyond the protocol. So I don't think that would be an issue at all to, things like that. I just wanted to make sure that I was understanding fully. So no, that.
So when you say protocol, what I just got there is you may be talking about protocol agencies that don't have the ability to change their own protocols. So state level protocols or something like that.
Yeah. So we cover 14 different counties, and each county has a different, other than a couple that are combined, and they may differ slightly. They're off of the same model, but there's certain flavor to each. I don't see it in the Airway as much, but I just had concern of if we're going to drastically try to change something, it's going to take a lot more than this period of time for me to do that.
My suggestion, Tim, is to do a one-on-one with one of us and really kind of dive deep into what you've got.
Yeah.
Working with and would just play dueling schedules and set that up to see if it makes sense or not.
Sounds great.
The other thing though, Mike, that I would say is that each system that is going to participate, or each organization that's going to participate, is going to have different constraints and challenges. And the constraints and challenges that you have, Tim, in your specific setup, that's going to be repeated across the country. And so, your choice to do an improvement the first one might not be the protocol change because it's going to be really hard. But in other organizations and agencies, it might be a little bit easier. And so, right, if you're Jeff Jarvis in Texas, you can change your organization's protocol on the drop of a dime. So, again, it might be easier for someone in a situation where there's a lot of that kind of flexibility, and but maybe not for someone like yourself in a different environment. And so that's part of what we've learned, is that different organizations will choose different strategies based on their constraints, and that's just a natural part of what we've got here.
Would you have a marketing package type document that's available that's at the medical director level that's going to help me answer some questions ahead of time for them? Was that something that exists?
Not sure it quite exists yet.
Okay.
But one of the things that I'm sure one of us would be happy to jump on a Zoom with you and your medical directors to talk it through with you.
Perfect.
That's an easy thing to do. We've got a couple other questions here. Bob asked the one, and Jeff, I think this is probably for you, about this is an intubation as a skill, not diving into supraglottic airways versus mask, as they may be a better choice. Do you want to?
Sure. Yeah, and I think the question is why for Airway 01, improvement of first pass success without hypoxia or hypotension, why we're just looking at intubation for that as opposed to supraglottic airway for that, or BVM for that. And Maya had reached out also and said, look, BVM is a really important thing to improve. Why don't we focus on that? And one of the reasons is measurement. It turns out that things like effective mask ventilation for a large measurement, when you're looking at trying to identify and consolidate around clear definitions, mask ventilation is really hard to identify from a measurement standpoint. When you're looking at individual cases, that's a whole different issue. But when you're trying to consolidate them into a standardized definition, it gets really challenging with the data that we have. So the question about why intubation as opposed to why supraglottics, one of the things that we know about intubation is that it is typically more challenging and takes longer than supraglottic airways. So in other words, supraglottic airways might be the solution to these patients getting profoundly hypoxic and hypotensive as you're intubating. In other words, if the solution to the Airway 01 problem is really focusing in on not just the technical skill, but the optimization of the physiology prior to the intubation attempt. And if you're not able to optimize the physiology, then use a different approach to airway management.
Yeah, the reason I brought it up is I'm in a very hybrid area here in Dallas-Fort Worth where I have rural and I have 8 helicopters, et cetera. And our QA meetings have taken on a different look with some of the AHA recommendations, et cetera, that you look at other options. You don't necessarily go to an ET tube immediately. And most of you guys probably know that most of the medics out there are going, but that's what we thought we were supposed to do. So the question was just based on, is there data before this that looked at SGAs? Because most agencies did an SGA because they failed. It wasn't that it would be a better option. So I was just wondering if there was something prior to this that looked at maybe a King or maybe an iGel, whatever, that your metrics look okay, or do we just? And I understand completely if we're just going to intubation, that's tough enough to tackle as it is. So it's just kind of a metric question.
Yeah, so the initial, and I completely understand your question. I think when you look at that initial measure, the Airway 01, when we initially wrote it, there were stratifications for supraglottic airways and intubation. And the challenge becomes those patients that you can't optimize the physiology on prior to airway placement. The solution for those patients in a lot of places is we just need to use the airway that is faster and more successful and easier to place, which is a supraglottic airway. So in other words, using a supraglottic as the primary instead of a rescue, that's the goal. And in that case, you are essentially changing the population to say you're never going to be able to improve that first pass without hypoxia or hypotension for supraglottics because you changed the population to those patients you can't optimize the physiology for.
Okay, I got it. That clarifies it for me. Thanks.
Yeah, and this is absolutely not, the intent is not to say these patients need to be intubated. As a matter of fact, I think one of the key lessons learned that we'll find as we go through this is that there are an awful lot of patients that we probably should not intubate. And one of the ways to improve this measure is remove them from the measure altogether and do something that is more successful for that patient.
That sounds good. So we got a question from Maria here about instances of people dropping out in the Lights and Siren project, and there were a number of the systems that initially signed up that ultimately were not able to participate effectively in the Lights and Siren process. So drinking our own Kool-Aid, we have revised the inclusion criteria for this project to try to mitigate some of the drop-off that happened during the Lights and Siren project. So that has definitely been taken into account, and we've got new theories that we're testing this time, and I'm sure we'll learn and revise for our third one. There's also Melody asked about could more than one person be able to participate in the virtual learning sessions, and absolutely we can handle a large number of people from that perspective. That's easy. We from an industry support of this research, it's not, first off, it's not research, it's improvement science, and that's an important distinction. But I don't believe we have any like funding source or any support for anything like that other than the amount that NEMSCO puts into it. Do we have anything like that, Cherie?
No, but it's a good point. There may be, but you can say right now that there is not. But I don't want to say that that may not happen.
And one thing I think that we probably should address, because there are several different types of ways that you can support. One of the things that really comes up with industry support is conflict of interest. So you would not see, for example, big waveform capnography, the Massimo supporting this to say, hey, you have to push our product. I don't think there's much of a chance of that happening just because of the types of things we're talking about here. But conflict of interest is something that we're always very mindful of. And we want to make sure, number one, we're as transparent as possible. And number two, we're always watching to mitigate any potential conflicts.
That's right. I would just speak for NEMSQA. You can look on our website to look at our corporate partners and to all of that. I mean, I think that the stance that we take is transparency and to ensure that people understand who are our corporate partners and who, it's oftentimes people who are like-minded, organizations that are like-minded and using data to improve patient outcomes. So maybe with that, we can move on to the next steps, Cherie, just because we've got only 2 minutes left. Oh, sorry.
Just one last one. Mick, your point about the IRB for the lights and siren. We worked with academic partners within our faculty group, and they submitted it to their IRB for the peer review publication for the Lights and Sirens project. And we will likely do the same for this one as well.
I just can't help but to make the point about this. The reason it's important, in case you aren't aware, lots of journals require an IRB approval. And because you don't technically need an IRB approval for improvement science, you don't need it. But the problem is we're not the ones who get to make the decision. The IRB has to be the one to say, you don't need IRB approval. So we have an IRB saying you don't need IRB approval. It's a bit of an odd catch-22, but we definitely took care of that.
Go ahead, Michael. Sorry.
No, I was just going to take the opportunity to move us on to the wrap up because we've got 2 minutes here. So Cherie, maybe I'll turn it over to you.
Yeah, thanks, Michael. So I will take 1 minute just to give us our next steps, which are really just to apply if you are interested in participating. I do just want to point out, so I put the link in the chat, there's also a QR code. When you go to the application, you will get this screen that if you have an existing profile, either because you've just created a profile to access the measures or you are a current member, when you sign in, it will then direct you to the application. If you have no connection to NEMSQA at this point, meaning you don't have a profile, just put your email in there and then it will bring you to the application. And the reason we do that is so that everything is connected in the documentation in our system. So we don't have to then ask you to complete contact information multiple times. It all just goes into your profile and we'll have all of those people all linked together. So it is 2 steps. First, you'll either log in with your current profile or just enter an email to move forward to the application page of that. And then, of course, be thinking about who your team members are, what data sources are, how you're going to get the measure information. The other next step, which is not on here because it just came up, is that if you are one of the people looking at potentially a group of agencies or a system, reach out and we can set up a chat with you to see what the best way is to enroll. And with that, unless there are any last comments from our
there's a last question that just got popped from Christine on the comparative statistics. So We don't do comparison in the traditional benchmarking kind of perspective, but each agency that's participating will have their own data populated in the Simple QI, which is the online platform that we use, and we will discuss best practices and milk the benefits of that kind of comparative statistical thinking.
With that, thanks everyone. Please feel free to reach out if you have any questions, and we'll look forward to working with many of you as we get started.